experts in this field. So over to you two, if that's okay. Let you introduce yourself.
Thank you. I'm just going to share some slides, so bear with us and hopefully everyone can see those.
We can.
Excellent.
Okay, so I'm Paul Wilson and I'm going to go first. Just before we start, we should probably introduce ourselves. So Joe and I are both at the University of Manchester. Joe is a professor in applied health research in the School of Nursing, and I'm a senior lecturer in the Centre for Primary Care. We co-lead a rapid service evaluation team that's funded by NIHR, and we do lots of policy evaluations and evaluations of the implementation of new things by people like NHS England and the Department of Health. We have a lot of other roles and responsibilities that I won't go into today because that'll probably take up about 20 minutes. So next slide, please, Joe. Thanks. We're going to go quite fast in this. Now, this is something that we would normally do in a much longer session. So as it said in the first slide, it's very much a bite-sized taster session. So we may cover a lot of content that you might have to watch back to pick up on. And one of the things we're interested in this session is a bit of feedback in terms of areas of interest or areas that you'd like more detail on. We can look at coming back and doing something in the future. So it will be very much a whistle-stop tour of implementation and evaluation, hopefully not so fast that you can't take on board some key messages. So this is what we're going to run through, not in any particular order, but we're going to start first with the implementation side of things and then move on to evaluation. So I'll kick off. Oh yes, I forgot about that slide. So we're very much testing out this format. Normally, as I said, it would take us a much longer session to go through the detail of what we're going to cover, but it's an opportunity to give you chunks of information that you might then decide that actually you want to explore that further. So we can do all that and discuss how to take forward at the end. So if you go to the next slide, please, Joe. I'm going to start off by talking about implementation, and these two sections are going to be linked. So Joe's going to cover evaluation. A lot of what I'm going to talk about is about things that you would evaluate, but I'm going to talk about taking a structured approach to bringing about a change in any shape or form. And I'm going to ground this in something called implementation science. And implementation science is very much a part of applied health research that is focused on evaluating changes in practice, changes in way of working, the introduction of new technologies, new drugs, new anything, even the implementation of training and whether that results in skill sets that can be demonstrated that people have been able to adapt and apply those skills in practice settings. Broadly, there are three areas to implementation science. Most implementation science studies start with some exploration of barriers and enablers to any change that may about to take place. We use that information to then construct strategies that will overcome the barriers, hopefully, and also enhance any sort of enabling features within a system to make sure that actually change occurs as we're intending. The third big part of implementation science is understanding those processes. So we evaluate change processes all the time. So what actually gets implemented, where, when, and most importantly, how. So that's really the focus of implementation science. There's an enormous literature out there that sits around this. Most of it is open access, so it's not behind paywalls or anything. So a lot of the things that I'll talk about today, you can Google and you should be able to get access to content that from the fields. So that's the good news. Next slide, please. I just want to make the point that implementing change is not new. And this is something that we've been, implementation science as a concept is quite new, but actually implementation research and trying to influence the way things get taken up and used in practice settings, particularly in health and social care, is something that we've been doing for decades and even hundreds of years. So here is the famous James Lind's study, which is a 200-year attempt to change practices in the British Navy. The man on the right-hand side is James Lancaster. So rather than focusing on James Lind, James Lancaster is the more interesting character. because he's a shining example of, just because you're famous and highly networked and a very influential character in the Navy doesn't necessarily mean that things that you spot and recognize and suggest should change are taken up in practice. James Lind comes along and is generally considered to have done what is the first controlled evaluation, so a comparative effectiveness of treatments for scurvy prevention. Some of them are quite eyebrow raising, as you could imagine. But this was on the back of James Lancaster's work. But as you can see, it took 150 years for somebody to try and formally evaluate things that he was noticing that were happening to in terms of scurvy prevalence in his own shipmates. Like all good researchers, it took James Lind several years to publish his work, and then it took an inordinate amount of time after that for somebody to act on those recommendations. The one that I always find staggering is that the British Navy mandates citrus fruit for all sailors on all journeys in 1795, but look at the gap between the merchant navy working out of the same ports, working out of the same organizational places of employment, you could say. Look at how long it takes them to implement the same recommendation. So this is just to emphasize that change can be challenging, but there are ways and means by which we can take a more structured and systematic approach to making sure these types of lags in uptake don't happen. Next slide, please. So very much implementation depends on what you want to do. There are lots of things that you might want to be seeking to implement in a practice setting. You might want to enable staff to learn new skills. You might be interested in promoting the uptake of a new medicine or medical device, introducing new technologies, digital technologies, virtual wards, all these sorts of things, very popular at the moment in terms of, but these are things that you might be thinking about doing. You might be looking to change how services are organized, and this is something that Joe and I spend a lot of time evaluating. So the service reconfiguration and change is something that's one of our specialisms. Changing how staff work, and maybe just something simple like, I say something simple, but we can go into that in a minute. Just making sure that guideline recommendations are actually adhered to in practice settings. Next slide, please. And against these types of implementation, types of change activities that you might be seeking to enact, you might want to know different things about those change strategies. You might want to know if it's actually worked, if the change has occurred. You might want to prove that something is actually being used in the way that you intended it or hoped that it would be. You might want to be showing that it's displaced activity from other aspects of healthcare. You might be wanting to show that it's actually made cost savings or some sort of savings in terms of or efficiencies in the way they work. You might just want to demonstrate that staff have learned a new task, a new skill, and are enacting that in practice. And behind all that, implementation is very much focused on process activities. You might want to demonstrate that some of these changes have actually resulted in better outcomes for patients. So those are all things that you might want to consider and you might want to evaluate, and Joe will speak to those shortly. Next slide, please. But how do we know something's changed? So we might have a good idea. So just to take the example of guideline recommendations, NICE, the National Institute for Care and Health Excellence, they disseminate and publish guidelines every single week of the year. So new recommendations about how we should work, the type of products that we should use, and so forth, are issued almost on a daily basis in this country. But just doing that doesn't mean that the right-hand column, something will happen as a result. People will change their practice. People will become aware. They'll absorb that knowledge and just routinely make it part of their new routine in terms of how they work. Next slide, please. ISLGAT is a term that's used often in implementation science, and we often think that just issuing a guideline recommendation is enough, and that the change that we want to see or we anticipate will happen as a result. And ISLAGAT is something that we've tried to leave behind, and ISLAGAT stands for it seemed like a good idea at the time. So just because we've got a good idea or we know something is what we should be doing doesn't mean that that will be enacted in practice in the way that we intended. And often the bit in the middle is the bit that we leave out and the bit that we don't spend enough time thinking about and developing and putting in structures and processes in place to make it happen. So change doesn't just happen by itself. Next slide, please. So as researchers, and I'm going to link this to something that's a bit more practical than some of the stuff that we use, we need to talk about theory. Next slide, please. So as researchers, we use theory all the time in our work. So generally, I've taken a very sociological definition here of a theory, an ordered set of assertions about a generic behavioral structure assumed to hold throughout a significant broad range of specific instances. That's nice and easy to understand, isn't it? So essentially what we're saying, we've got ideas about how things function in the world. Now, next slide, please. On the right-hand side of this diagram, we might have ideas that are quite grand. So we might think about things in a very abstract sense, like leadership and culture and so forth. And they might not be linked in a way that we can meaningfully apply that in a setting and understand whether it makes a difference or not. And just to use an example that links back to our diffusion example with scurvy prevention. So diffusion of innovations is a very famous implementation theory, and that would be a grand theory. So that essentially sets out how ideas spread in social systems. So how new stuff gets diffused and gets taken up and used in be that health system or any system. What we have in the middle of these two cycles of inquiry is something called mid-range theories. And mid-range theories are things that researchers develop from grand theories. So the idea of we've got a sense about how ideas spread, or how do we operationalize that, and what are the elements within that that would need to be in place for us to be able to evaluate and see if that actually happens or not. And we use mid-range theories a lot in our work to generate hypotheses around things that we think might work, put in place structures and processes, and then evaluate that change process. And then the cycle of inquiry should be, and this is the bit that never happens in research, should be that that information then feeds back into the mid-range theory and into the grand theory, so that we're always learning and accumulating new knowledge on how the world works and functions. Next slide, please. So just to take away the abstract element of it, here is a mid-range theory. This theory is called the Consolidated Framework for Implementation Research. Very long-winded, but essentially it's an operational framework of the diffusion of innovations. So how ideas spread in social systems, CIFAR as it's known in the trade, sets out here are the core ingredients that need to be in place for change to occur. And we've got 5 boxes on this slide in terms of there are things about the change that affects its uptake. So things about a new product or a new way of working or a new technology, whatever, in terms of whether it's got a relative advantage over the way we currently work, whether it fits with the way we currently work, whether it can be easily integrated, whether we can test it out before we, try before we buy, that sort of thing. So that's the characteristics of the intervention. Then there are things at the organizational level. Again, researchers like to come up with new words. So inner setting is essentially organizational level. So there are things about the way organizations are structured and the way we work can influence our ability to affect change in a system. And there are a whole load of constructs and active ingredients in that space that we need to be mindful of. Likewise, the outer setting, the wider environment, the wider health system, be that an ICB level or even beyond that, and sort of thinking about an NHS region or even NHS England itself, there are elements within that can affect our ability to enact change on the ground. And then there are the people involved. So implementation is always about people fundamentally and their knowledge, attitudes, their attributes and the skill sets can affect our ability to bring about change. And then the final box is the implementation process itself. So understanding the things that we need to do to bring about change is core in terms of to whether something actually gets taken up or not. Next slide, please. So that's me doing the research a bit. This is where I now bring it back down to something that I know you're all familiar with, and that's logic models. So our use of theory is similar to use of logic models, and we use logic models routinely now as well, in terms of we find that it's a very good way of articulating what needs to be done in order to bring about a change to link those outcomes that we are hoping to see versus activities. And so the mechanisms by which change will occur is what logic models try to set out. Next slide, please. And as you know, logic models have a series of boxes reading left to right, shall we say. So they're obviously the resources that we have available to deliver the change activities that we plan. They are the activities themselves, and I'll say a little bit about those in a minute. And then the outputs through to the outcomes that we'd like to see and the wider impacts that we hope to see. And really, if we think back to the two guys standing at their blackboard with their wondering what's missing in the middle of their equations, often the gap in logic models is between activities and outputs. So this bit is the bit that really matters. So are we doing things that will actually deliver the outputs and ultimately the outcomes that we want to see? And the way any sort of change process is going to work should be based on not only your own past professional experience of these sorts of similar change efforts in the past, but also we know a lot about how to implement things and how things work in health systems. So there's an evidence base that we should always be informing ourselves with. And one of the reasons why researchers use theory is most, particularly mid-range theories, are empirically grounded. So what I mean by that is people have done lots of research evaluating things that are similar, and that information feeds back into that mid-range theory. So we're using something that's already grounded in a practice reality. Logic models have that same element, but I think the heavy lifting that people often forget is working out that bit between activities and outputs. Next slide, please. So in logic models, activities, in implementation science, we call them strategies. So these are the things that we do to bring about change. And as you can see, there are a range of strategies. I've just taken out some of the common ones that people will be familiar with. These are all things that are done routinely in health systems. And these are all things that in implementation science have been evaluated to death. So something like audit and feedback as a change mechanism, there have been over 250 randomized control trials. So not even just evaluations, but large-scale randomized control trials have looked at developing and designing and refining audit and feedback processes. Most of that information never translates into practice settings, and the same can be said for all of these, from dissemination through to QI collaboratives. There are ways of operationalizing these strategies in a way that will bring about change in practice, but we're not very good at learning from what we already know about them. Next slide, please. So just to use audit and feedback as an example. So here are some core active ingredients that any audit and feedback process, most people just do audit in the NHS. So we gather information against a standard and look at it. But we don't think about using that as a part of a performance management or performance process. And these are the elements that really need to be, if you're doing audit and feedback, these are the things that you need to be doing routinely in order for it to affect change in the way that people work. And this can be mirrored across all the strategies that were on the previous slide. So optimizing strategies is part of that, filling that gap between activities and output. So understanding how a mechanism will bring about change, and then making sure that that process is actually enacted in practice will ensure that we'll see that jump from outputs to outcomes. And that's often the missing link. So taking a structured approach using implementation science is a way of doing this. Next slide, please. although it's very much a research-based discipline, it has much to offer in terms of practical application for just routine implementation processes. So even if it's about just measuring whether people have been on training courses and they've developed a necessary level of knowledge and awareness and skills on the back of it, those are things that implementation science can inform, as well as more considered change efforts within health systems, be that reorganization of service or just simple things like trying to bring a guideline recommendation into practice. So I'm going to stop there. That was very fast, and I'm being Scottish, I speak quickly. And Joe, do we want to jump on, or do you want to take some questions?
Yeah, I think what we'll do, if it's okay with people, is I'll do my bit, and then our aim is to leave a bit of time for questions at the end, for broader discussion. Is that okay with people? Yeah, we'll make sure we leave some time and we can pick anything else up as well. So nice to meet everybody. As Paul said at the beginning, my name's Jo. I'm an applied health researcher working on a number of evaluations at the moment. And just as a reminder, it's a bit of a grandiose statement saying I'm going to talk about all of evaluation. It's obviously a massive topic. So the aim of today was to focus in a little bit on something that I do and I'm a real fan of. And I've got a sort of aide-memoire picture to say it's not rocket science. And I realised that actually that's not true in this case, because even a simple evaluation kind of is rocket science. It's not easy doing evaluation. I do evaluation, you do evaluations. So I suppose the idea isn't me coming to sort of say, well, this is how I do it, and I think it's the right way of doing it. It's a kind of a conversation amongst people who do things in the evaluative space. And I'm wanting to share something we do that I find really useful in structuring evaluations, because I find that quite hard. And I'm interested in other people's experiences and whether this use of evaluation questions is an approach that you may do already, and that would be great to find out about. So I know you've had and you've got access to evaluation training, and so I just want to be clear about what the aim of this very short bite-sized taster session is around evaluation. So the training you've had, like a lot of evaluation training, covers a lot of ground and gives a big overview to doing evaluation, and that's really useful and really important. What I wanted to do here today, as a bit of a starter for 10, was to drill down in to some specific areas of evaluative activity, especially around shaping an evaluation. About anything really, but shaping an evaluation and starting to think about structuring decisions around the data that you're going to collect and how you're going to collect it. Because I think that's one of the most challenging things in an evaluation. You're kind of trying to generate a thread through your work, through what you want to know and how you're going to gather the relevant data. And that changes on an evaluation basis. So having some consistent approaches can be really useful, I find. Again, aware of the diversity of experience in the audience, so kind of interested in alternative views. So I'm echoing a bit what Paul said here already, but I've tried to simplify elements of evaluation in this health and care space down to some really kind of core stages. You have an innovation, an intervention, whatever you want to call it, something that you're going to do differently. You're going to change something, you're going to introduce something, or try and stop something. As Paul said, you're going to implement something, you're going to introduce it, and you're hoping that what you do is going to bring about change. So we haven't got lots of time to talk about these first two parts, but I just wanted to flag, in terms of innovation, what you're going to do differently. I'm not sure if these are things that you would use regularly. They're just tools that I find really helpful. This is called the Tidier framework. It's used in quite a lot of evaluative circles, and it's not the only tool, and we don't have a lot of time to go into it, but it's basically a checklist for helping you describe your intervention, your innovation, your change, what it looks like to people. Because fundamentally, in any evaluation report, you need to start with a clear description of what you did, because otherwise everything that follows it is really hard to comprehend, because you don't really know what was done. So frameworks like Tidy can be a really, really useful way, we find, of presenting that information to the reader, whether that be members of the organisation or people external to that, or even the people who took part in the evaluation themselves. And as Paul said, that information about your innovation, how you're going to introduce it, the mechanisms of change that sit around it to try and give it the biggest chance of success at achieving change, really sit in this space of a logic model around input and activities. And I should have stretched that circle a bit so it kind of overlapped with outputs, because obviously what an intervention or an innovation is, the thing you're evaluating, has different components. It might be training, it might be workforce changes, but then those may be wrapped around with implementation strategies or change mechanisms, strategies for change mechanism that maximize the chance of it having traction and success. So you need to have a clear idea of what you want this to do, and Paul's already talked about this. And this is where your outputs and your your outcomes come into play. And this is thinking about this thread through an evaluation. You're thinking, I know what I've got, I know how I'm going to introduce it to the people who are going to access this, and I know what I and the stakeholders around me want to know, and how what we want to try and capture. And those elements of any evaluation development are obviously crucial. So what I want to think about a little bit is this kind of sticky end of an evaluation, in terms of, okay, how do you demonstrate all of this? You've got a plan, you've got a vision. How do we demonstrate and capture this? And that's what a lot of, obviously, the previous training material that's available to you has started to talk about. And I just wanted to kind of delve into that a little bit today, and give the opportunity to do that. And very broadly speaking, you're thinking about capturing data of, did people introduce and use this innovation, this intervention, as was planned? And was any change that we were anticipating achieved? So we're kind of thinking again about our logic model and thinking about how we can capture the information that we've posited in that. And so this again is from your previous training material, and links to the idea of qualitative and quantitative data. How are you going to measure your change? What data are you going to collect? And I guess I want to focus on a very small part of this. That's a big topic. You know, we could talk for a year about qualitative research and a year about quantitative research. But what I want to do now is just think about, as I said, a strategy that we use to try and help us, and you might use as well, to try and help us think about, okay, along that thread of what we want to know, what type of data are going to be the most useful for us and our stakeholders. So we use evaluation questions essentially to replace the use of objectives. So often any evaluation has an overarching aim and a set of objectives, and they structure the data that you're going to collect and the methods that you're going to use to collect those data. And we've found it useful over time to iterate that more into a question format, and that this can help more transparently structure an evaluation. So, and some of the reasons for this is that forming objectives as questions forces you potentially to be more specific, and that process of specificity can be really, really useful, especially when you have multiple actors in a space all trying to move towards a shared vision of an evaluation. And that's often challenging, just taking people with you into understanding what you're going to get as a set of deliverables from an evaluation. And questions, forming questions, in our experience, can really help that. And as we've talked about, it links to logic models and it links to stakeholder engagement in terms of shaping questions. And use of evaluation questions can also manage expectations about what you can and can't do in an evaluation, and where to draw the line in terms of this is interesting, but we can't do this because we don't have the time and or the resources. And this is the implications of not being able to answer those questions. These are our priority questions. And a really useful thing about evaluation question structures is that they can then map directly to data collection. And to my mind, it really helps carry that thread through the conduct or the design and conduct of an evaluation, from your innovation, your change mechanisms, through to the change you want to measure, the questions, the question formats in which you're capturing the changes you want to measure, linking to the data that you're going to collect. So probably more useful here now is moving towards an example. So I've just, this is just to remind me, so some of I see these kind of objectives in evaluation work quite a lot, and I think they're really hard to work with because they don't really tell you what you're going to do or how you're going to do an evaluation. So these are these kind of very broad objectives, but we're going to evaluate training model X, we're going to assess the benefits, we're going to gain insights. They kind of sound fine, but actually when you try and unpick, right, what we're going to do, what's that mean, there's a lot of thinking to do to unpick behind those statements, and forcing the generation of evaluation questions can really help with that, I think. So just as an example to illustrate this, this is sort of based on some work we're doing, but it's also hypothetical. It's a variation on some work we're doing. Thinking about a short pilot of midwifery support workers in maternity care services. So this is the introduction of it's a workforce change, a new member of staff in midwifery teams to support antenatal care, especially around public health issues like smoking cessation. And this is going to be implemented, and we've got 9 months to evaluate this pilot. So I think someone might have just joined the call with, thank you. So just some examples of how we would take that and think about the generation of evaluation questions to support the design process. So form an evaluation aim, as I'm sure you would, to help give you a sense of the direction, where you want to be at the end of an evaluation, what you want to do. And then with various degrees of consultation, we might think, okay, what did this evaluation look like when it was implemented? We know what we wanted to do, but what did that look like practically on the ground? And then in terms of linking that to data collection, we would think, okay, we'd want to measure the number of midwifery support workers employed over time and maybe look at retention of staff once appointed. And that would link to areas of the logic model around how this introduction of this new staff member was going to achieve change. So then we'd think about questions around, what do we learn from the process of trying to change something? Not saying that you'd have the same questions for every evaluation. It depends whose perspective you're looking at it from. But we would potentially want to understand what the barriers and facilitators were to introducing this staff change from a staff perspective, to gain insights into that implementation process. And this very much lends itself to what Paul was talking to. We know what we wanted to do, but did it work? And this is where the use of interviews or surveys is often common. And those interviews and surveys can be shaped by frameworks. So Paul talked about the CIFA framework, and that had a number of headings or topics, such as what's the organizational context where this happened? What does the teams where this implementation happened? So probing those things within the data collection processes can be useful. And so that's where these frameworks and theories can help shape data collection. And that in that way, you're kind of drawing on previous data collection that's suggested what might be important in both inhibiting and supporting the implementation of things that change practice. So as well as thinking about barriers and facilitators, can ask questions about people's experiences. And again, those things, when we think about the forms of data collection, tend to use interviews or focus groups. So again, starting to try and think about the thread from the beginning through to, okay, we know how we're going to collect our data. So then there's other questions around, we could ask around, what difference did this change make? We've done something. Often people come to this question first. Actually, often there's kind of steps to get to this. Did this change outcomes for people? Often, first of all, we have to find out whether the intervention or the innovation was implemented correctly first before we can think about that. But these are formats of questions that can then be answered using specific forms of data collection. Sometimes it's hard to collect numerical data, quantitative data, especially in very rapid evaluation. So questions around looking at purposeful improvement that can be gathered based on people's experiences and opinion through interview and survey are also potential ways of collecting data. But this is where data collection around in this example, there's the potential to use number of missed appointments, number of attendances at specific antenatal classes, thinking about the types of outcome you want and how you're going to answer your question with available sources of routine data. And again, the transparency of this process, I find, really helps work through and support conversations with people in teams and services about what data they may have that may map to specific questions. And if there's an absence of data and you can't answer specific questions, you find that out upfront and can manage people's expectations around the deliverables. So really useful for supporting conversations. So that was an example, and I've just, as we said, we don't have a lot of time, but what I've tried to do is kind of try and pull lots of common questions or types of questions that we use into a typology. So just examples moving from left to right to sort of question types, broad sort of example text, and then some more specific examples of the type of questions we might ask in an evaluation. So this is about actually designing something. If you've got to focus on thinking what should we form this innovation from, going through to user experience and acceptability of services. And it's not that you ask all of these questions in an evaluation, and these are just examples. It's about being able to pick and have tools for discussion and to allow people to brainstorm and think about what they want to know. Questions about implementation, which we've talked about already. Questions about workforce, then again, this links to logic models. So the success of a particular innovation may be conditional on a set of activities happening within the way people work and communicate. And so an evaluation may want to drill down on that to understand whether that happens successfully, because all other outcomes are conditional on that change occurring. So I couldn't fit these ones in those nice pictures, so this is really different, but I just had to do these in a table format. So these are questions about clinical and cost effectiveness or variations on that. I'm aware that they might not be concepts that are as relevant to kind of workforce and training innovation, but thinking about whether you can compare to before your intervention and after your intervention, or people who did and didn't receive your intervention, to really demonstrate tangible change. These are the kind of questions, and really, really important. And we always try and focus on this, as I'm sure you do, to not always assume benefit. The focus on risk and unintended consequences in evaluation is obviously crucial. And again, in terms of in developing a logic model, there may be scope to surface with stakeholders some of their anticipated or some anticipation of risks and unintended consequences that can then shape the question formation. And of course, questions about access and equity of access. And as I've kind of alluded to, the question types, and there's some flexibility, and again, we could talk about this separately and unpick all of this and at a more granular level, but different types of questions broadly lend themselves to different types of data collection. And so hence, once you've decided your questions, you're already funneling yourself down to the methodologies and methods that are most appropriate to what you're going to do. And again, as I said, you know, this process of developing questions intersects with this to the degree that you can't really talk about one without the other, and that can be really useful because it can mean that you're not asking questions that you've got no hope of really meaningfully being able to answer. So I think all of this has really been covered. I'm happy. I want to make sure we leave some time for questions. And I guess I just really wanted to underline that we do this. This is how we work, and it may be how a number of you are working already, as I've said. So this is an example of an evaluation that we're doing at the moment. And this is some of the questions that we have generated in collaboration with a series of stakeholders, and these are still evolving, that are shaping our data collection around a novel service delivery programme that's being piloted at the moment. This is 6 of about 14 questions that go through a process of refinement, but this really is something that we do on a day-to-day basis. And I'll stop there. Thanks, everyone. Thanks for your time. So I don't know if people have questions. Sue, I don't know how you want to run the question.
Do we still have Sophie here? I think we might want to pause recording. That's what we normally do, and then open up to questions.